Morgan, and this is my week 7 presentation for nursing 711. I was given the assignment of chronic renal failure. This is case study number 31, chronic renal failure. Case introduction. Mr. M.A. is a 27-year-old white male who is visiting his primary healthcare provider to discuss some recent blood tests. He's been feeling fatigued and weak lately. 3 years ago, the patient presented to the emergency room with a 6-hour history of coughing up blood. He has also complained of difficulty breathing, chills, and chest pain. He has recently suffered a 2-week episode of influenza A. Lab tests revealed an elevated white blood cell count and iron deficiency anemia. A physical exam revealed moderate hepatosplenomegaly and inspiratory crackles at the base of each lung. He was hospitalized for a thorough clinical workup. An ELISA test was positive for antiglomerular basement membrane, or GBM, antibodies in the blood, but serum complement levels were within normal limits. Immunofluorescence of the renal biopsy was positive for IgG and complement lining of the glomerular membranes. A diagnosis of Goodpasture syndrome was made, and the patient was educated about Goodpasture syndrome, that it's a disease in which the immune system attacks the kidneys and the lungs, and that a potential serious complication is chronic renal failure. This patient was immediately placed on methylprednisolone. Dosage was 1 milligram per kilogram per day, PO every 6 to 12 hours, not per day. So twice a day, 2 to 4 times a day. And the plasmapheresis was conducted, so there were 4 plasma exchanges of 1 liter each daily for 2 weeks. After 2 weeks, the patient's symptoms resolved and the serum anti-GBM antibodies were no longer detectable. This patient was maintained for 6 months on azathioprine and 160 milligrams of trimethoprim plus 800 milligrams of sulfamethoxazole 3 times a week. The clinical course, with every patient visit at every 6-month interval, proteinuria and hematuria were becoming more severe. Increasing BUN and serum creatinine levels also suggested that the patient was having progressive kidney disease. The patient had 1 relapse at 1 year following the onset of his Goodpasture diagnosis, and he has been hospitalized and treated again with the methylprednisolone azathioprine, and plasmapheresis. At the patient's most recent visit with the nephrologist, his vital signs were BP of 150/95, a pulse of 90, respiratory rate of 22 and unlabored, and his temperature was 98.6. He is 5'9" and weighs about 170 pounds. The serum creatinine levels were compared with previous tests to determine the extent of progression of the renal failure as well. Chronic renal failure due to Goodpasture syndrome. So Goodpasture syndrome is an autoimmune attack from the anti-GBM antibodies, and they target the alpha-3 chain of the type 4 collagen in the glomeruli of the kidneys. It can lead to chronic renal failure through the autoimmune process, where the body produces the antibodies that attack the basement membranes in the kidneys, which causes severe and irreversible damage over time. This can lead to an autoimmune attack. The underlying cause of the disease is the production of the autoantibodies that target the collagen in the basement membranes of the glomeruli of the kidneys. This leads to inflammation and damage. When these antibodies bind to the GBM, they activate a very strong inflammatory response in the kidneys, which involves activation of the complement system. So the binding of antibodies triggers the complement cascade, which then attracts inflammatory cells. Neutrophils and macrophages will flood the area and release inflammatory mediators and enzymes. This ongoing inflammation will severely damage the delicate filtering units, or the glomeruli of the kidney. This will progress to chronic renal failure. The relentless damage to the glomeruli will impair the kidney's ability to filter waste products from the blood effectively, and if the disease is not treated quickly and aggressively, this damage can accumulate and will cause scarring or fibrosis, of the healthy kidney tissue, so it's replaced by scar tissue over time, which is not functional. It can cause nephron loss, so the number of functioning nephrons will decrease significantly. It can cause irreversible decline, so the persistent progressive loss of kidney function will ultimately result in end-stage renal disease, ESRD, or chronic renal failure. Early diagnosis and immediate aggressive treatment are essential to halt this immune attack and preserve kidney function to prevent the progression to chronic renal failure. Pathophysiology. So Goodpasture syndrome, we kind of talked about that already, but it's an autoimmune process where the body produces autoantibodies, usually of the IgG origin, that mistakenly target and attack specific protein in the basement membranes of the kidneys and the collagen, which causes rapid tissue destruction. A central component of Goodpasture syndrome is the development of the anti-GBM antibodies that are specifically targeted against the alpha-3 chain of type 4 collagen. This is typically found in the basement membranes of the renal glomeruli and the pulmonary alveoli, so the air sacs in the lungs. Goodpasture primarily affects these two organs, and the autoantigen is typically hidden within the structure of the basement membranes and becomes exposed to the immune system after an environmental trigger, which can be things like smoking, exposure to hydrocarbon solvents, or a viral infection like the patient had in case study 31, influenza A. Inflammatory damage process. This includes the autoantibodies binding to the basement membranes, which initiates the severe inflammatory cascade, activating the complement system, causing immune cell recruitment, tissue injury, and organ failure. Inflammation will stimulate the complement system to bind to antibodies, which attracts the inflammatory cells like neutrophils and macrophages. The tissue injury will occur due to the inflammatory cells releasing the enzymes and other mediators. These generate free oxygen radicals and will cause direct damage and necrosis to the basement membranes and surrounding tissues, which will lead to organ failure, particularly in the kidneys and the lungs, where the basement membranes contain the collagen that is damaged by these antibodies. In the kidneys, this leads to rapid crescentic glomerulonephritis and acute renal failure. In the lungs, this leads to pulmonary hemorrhage and respiratory failure. This is an aggressive and self-perpetuating cycle of antibody production and immune-mediated destruction, which rapidly damages the vital filtering and gas exchange functions of the kidneys and the lungs and leads to life-threatening conditions if not treated immediately. Chronic kidney failure is a self-perpetuating cycle of damage that occurs regardless of the initial cause of kidney injury. It causes widespread renal fibrosis, nephron loss, and the accumulation of uremic toxins. CKD will often begin with a specific underlying disease or injury like diabetes, hypertension, glomerulonephritis, and this causes an initial loss of functioning nephrons. In response, the remaining healthy nephrons will compensate by increasing their workload, which is a process known as compensatory hyperfiltration and hypertrophy. And this adaptation initially maintains the overall glomerular filtration rate, or the GFR. Progressive damage mechanisms occur while compensation helps in the short term, and sustained overwork, increased pressure, or glomerular hypertension and metabolic demands on the remaining nephrons are ultimately maladaptive and will lead to a vicious cycle of further injury. Key mechanisms of progressive damage include glomerulosclerosis and tubular interstitial fibrosis, which increases damage and scarring and of the glomerular filtering units in the surrounding tubules and interstitium. This fibrosis involves the replacement of functional kidney tissue with non-functional scar tissue. Inflammation and oxidative stress occurs. Chronic low-grade inflammation and increased oxidative stress are characteristic of CKD. Damaged cells will release the inflammatory mediators and reactive oxygen species that will recruit immune cells and cause further tissue injury. Hypoxia. Ongoing damage to the kidney's microvasculature leads to the reduced oxygen supply to the kidney tissues, which further exacerbates inflammation, apoptosis, and fibrosis. Proteinuria occurs in the presence of protein in the urine. It's a marker and a driver of CKD progression, which contributes to tubulointerstitial inflammation and scarring. Uremic toxin accumulation. As the GFR declines, waste products and uremic toxins build up in the body and contribute to the systemic inflammation, endothelial dysfunction, and damage to other organs, especially the cardiovascular system. Metabolic and endocrine derangements. CKD will cause imbalances in calcium and phosphorus metabolism, which leads to bone disease and vascular calcification, metabolic acidosis, and reduced production of essential hormones like erythropoietin, which will cause anemia in some patients, and activated vitamin D. End-stage renal disease. The relentless progression of these processes will result in a continuous loss of nephrons until the kidneys can no longer maintain adequate fluid, electrolyte, and acid-base homeostasis. This final stage, end-stage renal disease, can necessitate kidney replacement or therapies such as dialysis. The patient denied any bleeding, bruising, shortness of breath, chest pain, anorexia, nausea, vomiting, loss of coordination, unsteady gait, and bone pain. He did state, however, that his skin has been itching, and he's been using a lot of lotion in his arms and legs because sometimes it really bothers him. The patient is very pale, appears to be in mild acute distress. There are some periorbital edema and mild swelling in his hands. He reports a dull headache for the past 4 days, and that he's been forgetting things a lot more lately and can't seem to concentrate. At his most recent appointment, we went over the vital signs earlier, but he was hypertensive, and his serum creatinine tests were compared and showed that he is in progressive renal failure. Abnormal and ambiguous results included elevated sodium chloride, bicarb, BUN, magnesium, phosphate, alk phos, glucose, total bili, blood pH, and low results included potassium, calcium, creatinine, hemoglobin, hematocrit, RBC count, albumin, T protein. Diagnostic findings: the renal ultrasound showed significant bilateral atrophy, and chest x-ray showed basilar shadows, which are possibly contributing to pulmonary hemorrhage related to good pastures. In kidney disease, the calcium decreases due to the lack of active vitamin D, which impairs calcium absorption from food, and increased phosphorus levels, which combine to and lower serum calcium. This imbalance is a key component of CKD, and it can lead to weakened bones and higher risk of cardiovascular problems. The advanced practice nurse should focus on improving patient outcomes, coordinating complex care, and enhancing quality of life. Thorough assessment and diagnosis is really important in these patients because we want to treat things early. Diagnostics are important as well, like laboratory tests, creatinine, GFR, renal ultrasounds to monitor kidney function and the progression. Treatment planning and prescribing. So APNs should develop and implement evidence-based treatments based in collaboration with nephrologists and multidisciplinary team members. Medications for hypertension, diabetes, anemia, bone disease, and electrolyte imbalances should be implemented as well. In many cases, APNs may manage patients receiving hemodialysis or peritoneal dialysis, and they should be able to adjust dialysis prescriptions, monitor for complications, and participate in pre- and post-transplant care. The case question: so based on the patient's interval serum creatinine lab results, what is the approximate time to end-stage renal disease? So predicting this can be difficult due to individual variability in how patients reach the stage and the level of kidney function at which treatment begins. A common method for estimating progression and uses the plot of the reciprocal of calcium or serum creatinine against time, but this can have wide limits, and the exact date of dialysis onset or need for end-stage kidney therapy will vary. But given the provided data that we can observe the trend that the serum creatinine has increased from 1 to 7 in 3 years, that this is a rapid increase and indicates severe and aggressive kidney progression, and they are very close to or likely already in need of renal replacement or dialysis. The abnormal lung sounds are likely caused by, what is the likely cause of pulmonary lung sounds heard on auscultation? So it's likely caused by pulmonary hemorrhage, so the bleeding into the air sacs, which is why he went to the ER a few years ago. Or it could be pulmonary edema from the lung accumulation of fluid. What is the patho behind the patient's proteinuria and hematuria? The patho behind it is the Goodpasture syndrome causes damage to the glomerular filtration barrier, causing the targeted autoimmune attack. Hematuria occurs because the attack on the basilar or the glomerular basement membranes, which is the key component of the kidney's filtering units, and those are damaged. They're not able to filter things out as well. Binding of the anti-GBM to the collagen in the basement membrane will trigger the inflammatory response, which can disrupt the integrity of delicate glomerular capillaries. There can be RBC leakage from the bloodstream as well, and the glomerulonephritis sign, the presence of red blood cell casts, and dysmorphic or malformed red blood cells in the urine can often suggest glomerular origin. The proteinuria is also resulting from damage to the same filtration barrier, which allows large proteins, particularly albumin, to pass into the urine. Increased permeability also occurs due to the inflammation, damage, and destruction, and protein leakage can also occur from the blood into the Bowman space, eventually accumulating in the urine. These are my references. Thank you so much for listening.